Hey everyone, welcome back to the channel. Today, we're going to dive into a really important topic in endodontics, the consequences of an untreated MB2 canal, as well as how to locate, diagnose, and treat it effectively. It's like one of those topics that can really make or break the success of root canal therapy. So let's walk through everything you need to know. First off, let's talk about what happens if we miss the MB2 canal during treatment. So, in vital teeth with irreversible pulpitis, leaving the MB2 untreated can lead to persistent pain, especially in response to thermal stimuli. So, your patient might come back complaining of sensitivity or discomfort, even though you've already treated the main canals. And in necrotic teeth, it gets even trickier because the untreated MB2 can act as a bacterial reservoir, increasing the risk of periapical infection and ultimately treatment failure. Studies consistently show that untreated MB2 canals are like a major cause of persistent apical pathology and retreatment cases, which really emphasizes how crucial it is to locate and treat that canal properly. Now, some clinicians might think that if MB2 is covered by a dentin shelf, it's sealed off from bacteria and doesn't matter much, but that's not really the case. Back in 1917, Dr. Hess actually showed that MB1 and MB2 canals are interconnected by isthmuses, meaning that bacteria from MB1 can easily spread to MB2 and vice versa. So even if you think MB2 is hidden and isolated, it's probably still infected if MB1 was. Clinical studies have shown that periapical lesions often center around an untreated MB2 canal, which is why it's so critical to locate and manage it properly. One of the best tools we have today to help identify an untreated MB2 is cone beam computed tomography, or CBCT. CBCT imaging gives us a clear view of the entire root canal system, and it can highlight untreated MB2 canals, especially when you see a periapical lesion aligned perfectly with the MB2's apical exit. When that happens, you know that persistent infection is probably coming from that untreated canal. In these cases, non-surgical retreatment or even apicoectomy might be needed to resolve the issue. So, how common is MB2 in maxillary molars? Well, in maxillary first molars, it's present in about 90 to 95% of cases. In second molars, it's less common, but still significant enough that you should be vigilant every time you treat these teeth. Let's talk about the actual location of MB2 and some of the anatomy you need to keep in mind. MB2 is generally palatal to MB1, but it doesn't necessarily line up with the palatal canal. In first molars, MB2 usually sits about 1 to 3 millimeters palatal to MB1. Now, in addition to that, MB2 often lies in line with the mesiobuccal groove of the chamber floor, which can help you locate it. Also, it sometimes sits slightly mesial to an imaginary line drawn between MB1 and the palatal canal. So, using that as a guide can help orient you during exploration. In second molars, it tends to be even closer to MB1 than in first molars. Now, about the Denton shelf, this is especially relevant in middle-aged and older patients. Over time, MB2 can get buried under a layer of secondary dentin, forming what we call the Denton shelf. That dentin shelf has to be removed carefully, otherwise MB2 stays hidden and uninstrumented. And if you don't remove it, you simply can't access or clean the canal. The configuration of MB2 can also vary. Sometimes MB1 and MB2 remain separate all the way to the apex, but in other cases they converge before reaching the apex, forming an ovoid or figure 8 shaped orifice. That's why it's so important to confirm the final canal morphology using magnification and, if needed, CBCT before you complete the treatment. So let's walk through a typical clinical approach to finding and treating MB2. First, you need proper magnification and illumination, a microscope or at least good loupes with an LED light. Make sure you have good access to the pulp chamber before you start searching for MB2, and remove any obstructions like calcifications or the dentin shelf if necessary. Once that's done, identify MB1 and use it as a landmark. MB2 is usually about 1 to 3 millimeters palatal to MB1. Remember that in many cases, it lies along the mesiobuccal groove of the chamber floor and can even be slightly mesial to the imaginary line connecting MB1 and the palatal canal. So keep that in mind as you explore. So if you can't see it directly, gently explore the area with endodontic explorer like a DG16 or a micro explorer. Sometimes MB2 is completely hidden under the dentin shelf. In those cases, you'll need to carefully trough in a palatal direction using a slow speed round burr or a Mueller burr. The key is to be conservative. Don't be too aggressive or you risk perforation. In cases with significant calcification, you might need to trough about 1 to 2 millimeters apically to find MB2. Once you locate MB2, gently probe it with a small K file, usually a size 06, 08, or 10, and confirm patency. At this stage, you want to establish a glide path before you proceed with instrumentation. It's also important to confirm whether MB2 is independent or merges with MB1, and you can do that with a working length radiograph or CBCT imaging. When you're ready for instrumentation, use a crown down technique to gradually enlarge the canal. Frequent irrigation with sodium hypochlorite and EDTA is essential to remove debris and disinfect the canal. You might even consider using ultrasonic activation to enhance irrigant penetration. When it comes time to obturate, if MB1 and MB2 remain separate, you need to fill both canals individually. If they merge, you need to make sure the sealer flows adequately into the merged section. Techniques like warm vertical compaction or carrier-based obturation can help ensure a proper seal and reduce the risk of future leakage. And finally, sometimes, despite your best efforts, you just can't locate MB2. In those cases, it's really important to refer the patient to a specialist, an endodontist, who has the equipment and expertise to manage complex cases. If the tooth is severely calcified, you might need an endodontic microscope and CBCT imaging to locate MB2 accurately. In some cases, a pulpectomy can be done as an interim measure to relieve symptoms before referral. So that's the overview of the clinical importance of MB2 canals, from the consequences of missing them to the diagnostic tools and the step-by-step approach to finding and treating them. Thanks for tuning in, and if you found this helpful, please hit that like button and subscribe for more dental deep dives. See you in the next video.